Thank you to the organizers for asking me to give this talk. These are my conflicts of interest. I'd just like to show where my bias lies, because I've been asked to talk from bench to bedside, and my bias lies firmly towards the bedside. I'm a clinician, and in fact, I'm a pediatrician as well. So just so you're aware of where I'm coming from, that I'm not too familiar with the lab processes, but I have had some help in that regard. So what should be the natural progression in managing our patients with treatment failure? Obviously, you should have pre-treatment resistance testing, and if a patient fails the regimen, we have resistance testing, design a new regimen. That's the way it's done in the Western world. So what are the barriers to that natural progression? Why are we not doing this in sub-Saharan Africa? So firstly, there are logistic issues, costs, adherence is a problem, the barrier, and the span in the works. I'm going to address each of these four things. Let's look at logistics. Now, speaking to my colleagues who work in the lab, the biggest problem seems to be dry ice. Dry ice is very difficult to get hold of in Africa, and it's very expensive. And if you're going to centrifuge a sample and store it minus 70 degrees, it needs to be transported to the lab on dry ice. If you haven't got dry ice, you can get it to the lab in 2 to 3 days if it's transported at 4 degrees Celsius, but that doesn't always happen. And dry blood spots allow you to have a longer time to get to the lab, but the trade-off is reduced sensitivity near viral load of at least 5 to 10,000 copies per ml, and also needs a desiccant pack, which adds to the cost. Right, what about the costs? So to overcome the barriers, we can look at cheaper tests, less tests, more focused tests, and using surveillance to pick up trends and guide us in our treatment decisions. So cheaper tests, I'm very thankful to Professor Bob Schaefer for helping with the slide. So I'm not an expert on this, I'm not going to go into detail. The bottom line is there are cheaper tests which are available, okay, but very much dependent on labor, and you need to batch your samples, you need big numbers of samples, 100 samples at a time would reduce your costs, but of course it also adds to the turnaround time. And also costs don't include cost of sequences, which can be as much as 5 million rand for a machine. So what about doing less tests? In sub-Saharan Africa, obviously we can't afford to do baseline resistance testing, but we rely on surveillance, and that is being done pretty well. Patients failing a non-nucleoside regimen, well, we don't need resistance testing. We've got the Nadia and Artist study showing that if you change them from TEE to dolutegravir regimen, you don't need resistance testing, and Earnest second-line select showing the same with a PR regimen. Same thing with failed dolutegravir regimens. Earnest second-line and select telling us we can use a PR regimen second-line. We can have fully resistant NRTIs. We don't need resistance testing for that. So the one place where we still would need resistance testing would be after a failed PR regimen. And we're not certain if dolutegravir is going to change that. If you look at our South African adult third-line committee algorithm, you can see that patients need to have resistance to either lopinavir or atazanavir. We'll all get dolutegravir ritonavir plus 2 nukes. Okay, and if there's intermediate resistance or worse to tenofovir or AZT, or low level to darunavir, then add in dolutegravir. And if there's both resistance to the 2 nucleosides plus resistance to darunavir, they would add nitravir. And this has been validated, and this was in the days before dolutegravir, so they were using reltegravir instead of dolutegravir, and 80% of the patients had a viral load below 1,000 copies per ml in those who had a viral load done 6 months after switching to third line. But to do this, you need to know that they have PI resistance. So what about doing more focused tests? If we just need to know they've got PR resistance, okay, or we could argue with integrators as well, why do we need to look for reverse transcriptase resistance? Third line committee in South Africa requires PR resistance. So why don't you just do the PI test? Or in pediatrics, where you do integrase resistance as well, an integrase test as well. And then, so that will allow you to screen out those patients who need third line regimens. And then you can add in reverse transcriptase if you want. But some countries have basically got a generic third line regimen, you know, TLD plus darunavir. So then it doesn't really matter. You don't really need the reverse transcriptase. You can say this is a third-line patient, they get the third-line regimen. You're saving the costs of doing reverse transcriptase, which is quite a lot. In fact, one of the private labs will do a PI or integrase resistance only for $80 US, which is quite considerably cheaper than what we are getting at the moment. And the last way to reduce costs is to do surveillance to pick up resistance trends. So obviously, WHO, we're doing pre-treatment HIV drug resistance, very, very important. And that's on what we base the decisions to change our first-line regimen. And in fact, we've just done this recently, changed to dolutegravir. But what about acquired HIV drug resistance? So there are specific situations, and we can use surveillance to help us in those situations. For example, this was a situation, remember I'm a pediatrician, where we put together our 2019 new guidelines. This was obviously pre-Nadia and Artist. Patients were failing TE regimen would give AZD3C and dolutegravir. But if the patient is a non-adherent adolescent, this is not a great regimen because it's twice daily, not particularly well tolerated. All right. But you needed an active NRTI because we had a Dawning study, but it was pre-Nadia. Okay, but what about patients failing a Backup 3TC efavirenz? So according to the guidelines, they should also get AZT3C dolutegravir because then you're going to have an active NRTI and AZT. But these are adolescents. Are they going to take this twice daily regimen? No. So what about TLD in those patients? It would seem like it would be ideal. Okay. But a Backup can give rise to K65R. So then you've got resistance to tenofovir. You're not going to have an active NRTI. But how common is K65 after Backup in South Africa? And this is where we went to the lab and we said, you know, how common is K65R? And we looked at 2 pediatric cohorts, and one cohort, K65R was 6% in patients failing a non-nucleoside regimen, and 1% patients failing a PR regimen, and the other one, K65 was 1.8%. In fact, resistance to a Backup GSS below 2 was 7.8% in the Backup exposed, had resistance to tenofovir. So basically, putting them all together, we've really got less than 10% of patients failing a Backup 3TC regimen are going to have resistance to tenofovir. So now we have to make this decision. Do we punish the 90% of patients who don't have resistance to tenofovir, who could get by with TLD or once daily regimen, and say, no, we're going to give you a twice daily regimen because 10% of you have got resistance to tenofovir? And we don't even know what that means. Okay, but 10% have resistance to tenofovir. So but we're talking about non-adherent adolescents, so we took the public health approach to say, you know what, okay, we want to have the best good for the majority of our patients. So in our guidelines, all adolescents in South Africa failing the Backup 3TC efavirenz regimen will now receive TLD, providing, of course, they meet the criteria of being over 10 years and over 35 kilos. And yes, there will be 10% of patients who will have resistance to tenofovir, and we didn't even know what that meant at that point in time. And now we know in hindsight that with Nadia, that it probably wouldn't have made a major difference, and those 10% of probably will be okay because of the Nadia study. But that's how I'm showing we can use the lab and doing resistance testing on a cohort of patients to determine the trends that allow us to plan our guidelines. Now, what about adherence? I'm sure you're surprised, say, why am I putting adherence as a barrier to resistance testing? The problem is, and I'm sure you've seen it, okay, if the patients are not adherent, we will not get an accurate resistance testing. We're wild type, kind of susceptible to everything, and it doesn't help us. And the problem is that no patient wants to be caught in a lie. So if you say, are you adhering? Are you taking a treatment? Yes, I'm taking a treatment. Then you say, we're going to do this resistance test, but you have to be taking your treatment for it to be accurate. Are you taking a treatment? They're not going to say, oh, doctor, you know, I was lying before. No, of course, you're not going to be caught in a lie. So they're going to say, yes, I'm adhering. They'll do it, and it'll be susceptible to everything. It's not going to help us. Okay, so how do we get away? So what I do is I just say to the patients, look, I know things might have happened before, but we want to get an accurate test. So just for 1 month from now on, take it every day, and then we do resistance testing. And that way we don't have to force them to lie, because we're not asking what happened before. We just say, for 1 month, please take it. And I must say, since I've been doing that, it's a long time since I've got susceptible to all, showing the patient not adhering. And in fact, there's a study published recently showing that you can do ARV drug levels, which will also, assess if they're adherent, and with a good correlation with adherence and resistance. And then obviously you would only do resistance testing on the ones who've got detectable drug levels. So in other words, you're screening out those patients who are adherent to do resistance testing on them. If you don't have adequate drug levels, then obviously you would tackle adherence again. So that's certainly what we can do. Remember that the cost of drug level testing is 1/10 the cost of resistance testing, but there are also logistic issues as well. But you could, for example, if you're going to send the resistance testing on dry ice, you could send a specimen for drug levels on dry ice too. They could do the drug levels first and then only process the resistance testing if the drug levels are adequate. Right, so what about the spanner in the works? So what am I talking about? It's not necessarily a bad spanner. Dietetic. Why? Because dietetic is now being used first line, second line, third line, and obviously Nadia and artists have spearheaded this. The fact that we're not so worried about neural tube defects as well has pushed this to the fore, and literally we are seeing patients on first line, second line, third line dietetic, and we are starting to see less resistance. Countries that are using dietetic are seeing 90% of the patients suppressed. In Botswana, I've had a discussion with Dr. Avalos, and definitely they are seeing less resistance. Whether this is short term, probably, because you're going to start seeing dietetic resistance in a few years' time, and then of course, we'll have to go back. But in the meantime, there's going to be less resistance testing done because dietetic is going to solve the problem. So we might have to wait for this pendulum to swing back before we need to continue this discussion, because maybe we don't need so much resistance testing, and we're not going to get the bulk kind of testing that we need to drop the prices. So we might need to wait for dietetic resistance to start coming back before we start this discussion again. And what about dietetic resistance? As you know, very unusual first line failures, things like drug interactions, rifampicin, positive cations for sure, but we need surveillance, we need to monitor it, because we need to know what's going on, especially with Nadia, Artist, and Depth. Yes, they're showing great results so far, really fantastic and gratifying. But 4 patients in the Nadia study had dietetic resistance. And the interesting thing is 3 were in the AZT arm, which is with an active NRTI, and only 1 with a tenofovir arm where there may not have been an active NRTI. So it's not like there's going to be no resistance. We will have resistance. I recently came across a patient, high-level dietetic resistance, less than 2 years after switching to TLD from a suppressed protease inhibitor regimen. They were virally suppressed, and now I've got high-level dietetic resistance. Very, very worrying. And as it says, dietetic being used first line, second line, and third line quite willy-nilly. So watch the space. We are going to see dietetic resistance. And then, yes, we will need to revisit this discussion, because we are going to need to be doing more resistance testing. So to summarize, I think the important thing is that, as you've seen, clinicians and virologists need to be talking to each other. Okay, it makes a very big difference. I found it phenomenal that I've got these people that I can talk to, and it helps me a lot. Resistance testing needs to be made more affordable and available. We need to be more focused about when we do resistance testing. Surveillance is vital, but we need to target our surveillance as well to answer our clinical questions. And perhaps there's going to be a lull now because of the rollout of dietetic regimens, but beware dietetic resistance. Just like to acknowledge the people who helped me putting this talk together. Thank you very much for your attention.